Suppose your imagination is out of control. There is in front of you on a screen a man. And this man has a fedora pulled down over him, and his head is turned to the right, and he's cupping a cigarette to light it. And he's got his anorak, or his epaulette trench coat on. Who is he? And don't tell me it's Humphrey Bogart in Casablanca, because you'd be wrong. It ain't much more than 15. But that's just enough to squeeze the sponge, push the blood out of the chest, let it come back in again, just enough to get forward flow. So if you're going to put an IV in somebody who's deader than a doornail, try for the arm. And don't waste a lot of time looking for any other place. Throw a tourniquet around both upper extremities and try for whatever vein is the most obvious. You won't but think back to yesteryear. Right? And you put that hot needle in somebody, right? And if you were going to give some significant chemical, like a vasopressor, through that needle, what would happen was inevitably the needle in the skin, the puncture of the vein, the puncture of the skin would be very close together, and whatever that garbage was would back out around the needle. And pretty soon, if it was Levophed, there would be this nice little red spot. And then there would be this nice little dark red spot. And then this would be light brown spot. Catheters, right? Polyethylene catheter. And that polyethylene catheter fit through a needle. And some of these polyethylene catheters were this long. You could put them in a vein and they go all the way to the heart and then some. And because they fit through a needle, they were called through the needle catheters, and that's their name, technical name. He had a friend working in another hospital. You went out and visited him, and when you went out and visited him, you inadvertently came home with a dozen of these, right? In fact, you'd like to leave it in as long as possible. Alky, alky, forever, ever, right? By and by, forever. Well, what would you do? You'd put a mask on your face? You put a hat on your head? You wash your hands for 10 minutes? And how long do you think that catheter stayed in somebody after you did all that work? About as long as it stayed if you hadn't done any of it, 3 days. Okay? But if, in fact, you were busy changing IVs on 100 patients, supposed to have fibrin collections or platelet collections at the tip, they could stay forever. Even if you scrubbed and put on a mask and wore gloves, how long do you think they lasted? Same amount of time that the others did, about 3 days. Okay, so we have two styles. We have through and over the needle, right? Both are about equally cumbersome. You're equally facile with each, which is one over the other. Right? Both of them have the same kind of problems. Both of them generate hematomas at the margin. Both of them generate a fair amount of phlebitis. Both of them generate a significant amount of local cellulitis. You have to make an assumption when you put a catheter in somebody who, in fact, is about to undergo catheterization because he's dead in a doornail, and that is sometimes your sterile technique leaves a bit to be desired. The pressure's on you to get an IV started. Cleanliness becomes less important than speed. You will nod your head and say, never. But sometimes that happens. You have to forgive yourself. You make an assumption, for example, that a catheter IV brought in from the field is always dirty. Always. And should be changed literally within the first hours of admission. Be that as it may. Now you get ready for the guy who gives you the Thule intern question next year. Because that's the typical brand new R2 wants to hand the brand new intern, show him how smart he is, how masterful he is. First time it's ever happened to him. Right? Possibly. Absolutely. Come right up here and park. Okay? Now see why we needed to get rid of the first row? Handsome devil that you are. Okay, now you go to the theater. What happens to you when you go to the theater? You suspend your disbelief, right? Okay, so this is not a classroom. This is someplace. He's on his back, his head is down, right? He's in need of this particular device. Okay? He's in need of it. Now, how do we do this? First, we have to have the shirt off, right? Got to have your shirt off. I'm sorry to do this to you, but after all, it's part of the rules of being a medical student. You can be used as an example anytime.
Yes.
Okay, yes, sir. Thank you very much. Okay, well, we've got to think about anatomy, right? Got to think about a few things. Got to size it up, like the logger would say. Size it up. walk in, got to do this particular thing, we size it up. What do we size up first? Well, it's nice to always know where the manubrium is. And it's nice also to know where his acromion is, and you split the difference. When you split the difference, you should be at about the dog leg of the clavicle. Remember, the old clavicle makes a dog leg to the rear. That's where you want to be. And you say to yourself, that's where I'd like to be, right there. How do I know where I want to be? I'll mark it with my handy-dandy pen. At least I make a mark there, not a pen mark, just a mark. And then I take a minute or two and I very carefully make sure that I got a mask on, a set of gloves. I might even want to put a hat on. I might, in certain circumstances, want some bracelets on, right? Some wristlets, right? Because I don't need to get anything on myself. Then I take a little bit of iodine, and it ain't a little dab will do you iodine, the sort of surgeon's approach. It's from here to here, or maybe even we could say down to the nipple line. And from the midline across out to the shoulder, let's make sure the guy's clean. And if he's a hairy bear, take a minute or two and get rid of some of the hair, for no other reason than it's going to make things a lot easier later on for you. Okay? Take some 2% or 1% lidocaine without and make a nice wheel there. A nice wheel. Big one. Big one. Quarter size or bigger. And then let it set up. And then go right down on the bone. And take a minute or two and make sure that that whole periosteum on the top side and the bottom side of that poor clavicle is well anesthetized. Why? I didn't put this back together last time, forsooth. Okay? So we can set up and we'll do some things which are moderately efficient. Whether we're using a Seldinger or the old-fashioned approach, we'll put this back together. Always have your props ready, it says in Magic number 103. You've all taken Magic 103? Okay, so what happens? We get our handy-dandy bottle of saline. Get our handy-dandy bottle of saline out, and we draw up 1 cc, or maybe in this 10 cc syringe, 2 cc's of handy-dandy saline, right? We leave it right there for a minute. We open up our catheter. We throw the tip on the floor because this is Harborview. Somebody will pick up after you later. Some bald-headed old idiot will come around and pick up and growl the whole time. We'll throw this down. Going to save that. Going to throw that on the floor, right? Because this is Harborview, right? We can throw it on the floor. And we're going to take this nice thing out. We're going to make sure this catheter fits through the needle. Very gently, we're going to lay the catheter right next to the needle guide, and we're going to take the needle, this wonderful needle, sharper than a razor, and hook it onto this syringe with the needle and the numbers, the bevel and the numbers, what? Parallel. Why? Because ultimately, we're going to lose sight of that bevel because we're going to slide it right into the clavicle. Suddenly, we're going to get a wonderful show of blood. We're going to think, eureka! And then we're going to have to be able to turn that needle 90 degrees to the south to facilitate the catheter's turning the corner when it hits up against the wall of the superior vena cava, okay? Or whatever it hits up against the wall of. We'd like to know where the bevel is. We want to know where the bevel is. Let's turn the numbers to where the bevel is. So line the numbers and the bevel up, okay? The 2 cc's of saline is a bubbleator, right? A bubbleator. You know you're in the thorax when you get bubbles through your bubbleator. Okay, so it's a safety device. We have a bag put up. We got the 1,000 cc's of ringers. We got the anesthesia extension tubing on the very end. We got the three-way stopcock, and we got the ad set that has no back valves in it, which means it's clean. There's no little black balls, no little white balls in there to prevent backflow. We know it's charged. We know it's ready to go. So all we have to do eventually is hook it up. Okay? So now he's anesthetized. This lidocaine is set up. He's happy as a clam. We have him turn his head a little bit, and we say to ourselves, where do we want to be? We want to be in an imaginary vessel which sits right behind that not very imaginary bone. It's always right there. It's a little bit above it and a little bit behind it. So the way we do this is fairly straightforward. We're working from his right side. We put a finger, we'll use my thumb for the purposes of identification. Suspend your disbelief, it's really my index finger. We'll let our index finger, knee, thumb fall off the back or top of the manubrium. We'll know that if it's fallen off the top of the manubrium, it's now at exactly the same level as the anterior margin of the vessel. So that's the depth at which I wish to be. That's my triangulated target. That's what I'm going to shoot for. And in I go. I go in my nice little wheel and I hit the clavicle. I hit the clavicle and I bounce off, and lo and behold, he doesn't move because it's well anesthetized. A little negative pressure, I bounce off, and I aim right for the tip of my index, knee, thumb. That's the depth I wish to be, and I should be able to slide into a vessel, and I should hit it at about an angle of maybe plus 10 degrees, right? And if I'm really smart and really lucky, I get an instant show of blood, nice venous blood, and what's the very first thing I do? I rotate that syringe southbound. 90 degrees to the south, which means the bevel, the numbers, have turned 90 degrees. Okay, nice show of blood, no problems. I want to be able to place a catheter or a wire in there. Either way, I'd like to have this guy, if I'm going to put a catheter in, take a deep breath, let it all out, take another deep breath, and at this point in time, with him in maximum inspiration, I take off the syringe, pitch it on the floor, because this is Harborview. After all, somebody will pick it up, and in goes the catheter, right? The catheter goes in, the needle's southbound, the bevel's southbound, the catheter goes all the way to the hub, and we lock it down. And if in reality that's happening, that catheter is someplace about halfway to his ankles. I only need it to be right here. So ultimately I'll be able to pull it out, but I can think about that in a minute because I already mentally pre-measured that distance. Right, out comes a stylet, I pitch that on the floor, right, because this is Harborview and somebody will around to pick it up and growl the whole time. I reach over and carefully, having placed the line where I can reach it, and hook it up and drop the bag and make sure I have a blood flow. And if everything's working fine, out comes the needle. When the needle margin clears the skin, on goes the needle guard. Okay, now tell me that the Sellinger wire technique is any different than this. It isn't. In goes the needle, down goes the wire, out comes the needle, you pitch that on the floor, in goes the introducer or the expander, down goes the catheter. Right? It's the same maneuver. The techniques are exactly the same. The tools are slightly different, so neither should intimidate you. You ought to be able to move back and forth from one to the other. Okay? Always have negative pressure both going in and coming back, because you may in fact go through the vessels, push the walls together, suddenly coming through the posterior wall, you're open and you're in the middle of the vessel. Occasionally you'll have blood come back into the barrel of the syringe on its own volition. There'll be no negative pressure, and this will be bright red, cheerful looking, oxygenated blood, and you say to yourself, nastiness, you know. The words that you would then say are unprintable. No, most of the time. You can read about them in Doonesbury, but most of the time they're unprintable. What would you do? Well, you're in the artery, right? So you come back out, take a moment or two, take a few deep breaths, take a couple 4x4s and smash them right down into the superior part of the fossa, right in the supraclavicular space against the artery. And if you're really in stress, try it again. Otherwise, go to the other side. But you can get around that. Suppose you got to put a subclavian in a 300-pounder. Suppose you got to put it in somebody who's really significantly large. Maybe they got huge pectorali because they've been lifting 300 bench pressing. Suppose you're dealing with a lunger, guy who's been supporting tobacco for all of his, 45 of his 50 years. Everybody in East North Carolina's got a new Chevrolet because of this guy. You need to think about always a fallback, or maybe the subclavian is your fallback. The fallback, or the nice thing about the subclavian, is somebody can be bagging over here, somebody can be pumping on his chest, and you can be putting a subclavian in, and neither gets in anybody else's way. But the second technique requires you to do some manipulation, which means the guy bagging is at a disadvantage. Push on my hand ever so slightly, okay? We pick it up in the neck when it sits anterior, right, or around the anterior margin of the sternal component of the sternocleidomastoid, the clavicular component, and the clavicle. Remember, the only thing covers it is a platysma. Okay? And the last place we could have access to it is aiming for the confluence. Confluence of the sternocleidomastoid, arc, nipple, shoulder. Bisect it. Okay? Arc from here to here. Bisect it. Aim for the bisection. You could aim for here, you could aim for here. Aim for the bisection. Okay? Bisect that arc, take a 19-gauge needle at the margin of the sternocleidomastoid and literally the depth of the backside of that muscle and aim for this space. Aim, in reality, for the bisection. Nice little drip, 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 drip of blood. Take a big catheter, parallel it along the 19-gauge, and you're home free. You've intersected that vessel at about, what, 45, 30 degrees? Second approach is what I like to call the Cook County approach. So people like me with a 1 mouse power brain, right? 2 fingers. 2 fingers. Lateral, or at least at the margin, lateral margin of the clavicular component of this muscle, aim for the confluence. Sliding over the top of the muscle, you'll be anterior to the axillary artery, or the subclavian artery, and on top of it, I hope. Now, if it were me, and my 1 mouse per hour brain, 2 over, 2 up, same-sided big toe. Piece of cake. Okay? Now, do we use this subclavian as a resuscitation line? We decided the other day flow is a function of the 4th power of the radius, proportionally direct, inversely proportional to the length. How much can you get through this sucker? Not very much. Even we put an introducer, we don't have just a cordis in there. We don't have much. We have a long distance. We have something that's at least that long. Dissect along the vessel and slip this sucker in. Actually, it'd be nice if we could slip in just the IV tubing. But if we're going to use a needle, let's use this. And we put one here in the cephalic, one on the median basilic, one on the other side, one here. We can give several liters per minute. We can almost give 3. Okay? This idea of doing cut downs in the lower extremities kind of jostles my cavities. Makes them hurt. Okay? Big vessels, cut down on the upper extremities. Now, for the sake of the record, subclavian's kind of hard to come by, right? I mean, they don't just offer them up to you every day, do they? They don't say, hey, how'd you like to start a subclavian for us? So how are we going to learn how to do this? How are we going to learn how to do this? There's a dirty old man just picked up the stuff off the floor. I missed that one? Okay. Thank you very much for reminding me I missed that one. And put your toys back together so they'll be ready next time. Oh, Christ. I'm way behind today. Huh? How are we going to learn how to do this? We've got to have somebody to practice on, right? You got a rubber dummy that can get a subclavian. Actually, have a rubber dummy you can start a subclavian on. Right? No longer do we need humans. All we need is rubber dummies. You can put your shirt on and we'll give you a round of applause for Academy Award performance. Huh?
Thank you.
Right? Well, do people die in the CR? Unfortunately, yes. Do we help try to keep them alive? Yeah. Do we occasionally start subclavians on them? Yeah. Well, one of the things that I suggest that you do is, as an individual is prepared either for the medical examiner or his funeral parlor, that we make an effort to learn how to do this on that recently deceased person. Okay? Single puncture wound. We work very diligently, having made sure that we've given all of our muscle to the nurses so that this individual is clean, ready to go. Then I think it's important, it behooves us all, together in the room with the only equipment that we have, so it's in that little box. And everybody makes an effort to learn these 2 techniques. So we can write down on the medical examiner's form, subclavian attempt right, IJ attempt right. Okay? The same could be said of intubation.